Welcome to School of Complex PCI. This is Dr. Arash Hashemi, interventional cardiologist from Irfan General Hospital. The case is done with collaboration of Dr. Arsis Ahmediye and is titled What to Do with an Underexpanded Undilatable Stent. So our patient was a 75-year-old female with history of PCI and LAD with two overlapping drug-eluting stents 1 week ago in another center, and they referred us for the patient for bailout management. In the other center, the original operator didn't do much sufficient predilation and managed to put a 2.75 stent in LAD. The stent was severely underexpanded, and then they tried to do post-dilation with NC balloons and then high-pressure opium balloons, 3 up to 35 atmospheres, but they were no luck. This is the diagnostic angiography in our center. So as you can see, the femoral approach with 7 French guiding, and you can see the stents in LAD which are severely underexpanded, and there's a lot of calcification behind the stent struts, especially in this position. You can see a bulk of calcium behind the stent struts, resulting in severe underexpansion and an undilatable stent. For this patient, we can leave it alone. We can try to do it with opium high pressure NC balloons. We can try with another size NC balloon and go for longer inflation duration. We can go for cutting or scoring balloons. We can put another stent in the stent and try to expand it, and then we can send the patient to surgery. All of the above options are not good options, and there are some interventional options also, as we will discuss. So the best option with best results and the lowest risks is to do, if available, is laser or shockwave balloon therapy, and if they're not available, is to perform stent ablation with rotablator. I will take a moment to discuss the other options. Leaving it alone is not a good option because the risk of stent thrombosis is very high. Opium high pressure NC balloons, they already tried and failed. Upsizing the stent NC balloon is not a good option because the key is to add more pressure and add more time, not to oversize the balloon. The risk of rupture with oversized balloons are too much high. Cutting or scoring balloons, they are in the textbooks and some case reports, but after you put the stents, they have limited role in, and in our experience, they do not help at all. Putting another stent is just about the worst thing you can do, because you will double your problem, and it won't help and help with nothing, and it ameliorates your other options very much. And the surgery is a last resort in this case. As I stated, the best options are shockwave balloon therapy or laser at first, which are not available in our country. And the second best option is to do stent ablation with rotablator. So I will walk you through the procedural steps. Guiding is EBU 7 by 3.5, wire acetylene blue, and then change over fine cross to rota sapphire. Rotaverse for start is 1.5, and we use the femoral axis. So as you can see, there are a couple of tips and tricks for this procedure. First of all, you have to make sure that your backup is good, your surgical backup and your surgical room is ready, because the risk of perforation is high. You have to have stent grafts and coilings and materials which are necessary to address the perforation. And then you will start with rotating, and then it's basically what you want to do is to rota over the stent. And as you can see, we did multiple runs and then alternating the rota with NC balloon and opium balloon high pressures. So the goal is here to just ameliorate the stent altogether as much as you could. It needs multiple runs, it needs multiple bears, and then as you can see, we did it a couple of times, and every time alternate the balloon with the rota, and so multiple alternative rota runs and NC high pressure dilation, and then we have to check for IBUS for bit, or even better with OCT. And the goal is to fracture and crack the stent and literally ablate it, and then get rid of the calcium behind, and then put another stent. So after multiple rota runs and aggressive NC post dilation, we decided to upgrade rotaver to 1.75. These are the runs with 1.75. As you can see, we gradually increase the rotation, and we went up to 175,000, and you have to give time between the runs because it needs to cool down, and you have to watch out for no reflow phenomena. And after multiple runs, we are here. As you can see, it's very well expanded. So after multiple rota and balloon pulse dilation, IBUS run showed fraction in previous stent and then ablated previous stent and relative debulking calcium burden. So we decided to stent over the ablated old fractured previous stent, and we put a 3.5 and then post dilate with 3.7. So this is a final result. It's very nice. The stent is expanded completely. As you can see, the IBUS run pre and post rota ablation and the OCT run. And this is courtesy of Dr. Jalal Norouzi for 3D image reconstruction. As you can see, the whole idea behind the stent ablation is to literally ablate the stent and make it to some kind of powder, which it's scary, but it doesn't affect the distal bedding at all in our experience, which is a couple of patients now. We have a very little rate of no reflow phenomenon. So there are a couple of tips and tricks here. We have to keep ACT a little bit higher. Between rota runs, we have to give time to temperature to cool down. For 360-degree effect, it's better to move rota wire in different positions and end vessels to change the point of rota impact. And for the same reason, it's better to change rota soft wire to stiff wire to get a different point of impact. And then we have to be ready for no reflow treatment, and it's better to lower the LVDP before the procedure. And as usual with rota procedures, we have to prepare for ruptures. So what happens in rota ablation? The greatest concern with longitudinal stent ablation is to slip through the underexpanded stent without ablating the metal and leaving the burr immovable. So we advance the burr more gradually and more carefully, and the other concern is slow flow and no reflow due to metallic debris and stent thrombosis due to heat generation, and hence we waited a short time between each run to avoid overheating. Stent fracture, which happens in our case, is another concern, but actually this is a good sign. So multiple OCT and IBUS studies and also electron microscopic evaluation has shown that stent ablation by rota can remove underexpanded stented trots. And it's important to remember not to deploy a stent in a balloon on expandable lesions, as after deploying the stent, treatment options quickly diminish. Rota ablation has become common practice for lesion preparation prior to the stent deployment, but after that, as I told before, the first and best and safest option is shockwave therapy, which is not available everywhere. The other option is laser treatment, which is also unavailable in many countries. And finally, the stent rota ablation. So in this situation, there are limited studies to know which is the best treatment option, but the way of evidence is in favor of rota stent ablation if shockwave therapy and laser are not available. Thanks a lot for your attention.